Hi, thank you for joining us. I'm your host, Nadia Youssef. Today we have with us our orthopedic surgeon, Dr. Trevor Murray, and we'll be discussing joint replacement, and we'll be taking your questions live. So if you guys have any questions, make sure you put them in the comment section below. And before we begin, please remember this is for informational purposes only, and it's not intended to replace your own physician's advice. Thank you so much for being here today. If you want to just take a few minutes to introduce yourself to our audience.
Sure, thanks for having me. I'm looking forward to it. As she said, my name's Trevor Murray. I'm an adult reconstruction surgeon here at the Cleveland Clinic. A little background, I was actually a resident here from 2004 to 2010, where I did a residency in orthopedic surgery, and then I went to Chicago for a year to do a fellowship, which was a year of specialization in total hip and total knee replacements. And now I've been back here on staff since August of 2011. Wow. So almost 7 years. Yeah, it goes really fast. Yeah. I specialize in total hip and total knee replacements, including partial knee replacements, and then also revision surgery, trying to take care of hip and knee replacements that aren't working appropriately.
Great. Well, thank you for being here today. And I want to kind of start off with a general question.
Sure.
What is osteoarthritis and why knees and hips are affected by it?
In short, osteoarthritis is the loss of cartilage on the end of our bones. And so typically cartilage is a very frictionless, smooth surface, which allows us to move our joints freely and without pain. Osteoarthritis is when we start to lose that surface on the end of our bones. It can affect any joint in the body. It's common in the hip and knee. It's actually most common in the knee due to the fact that they're weight-bearing joints. Okay. The etiology or where it comes from, we're not exactly sure. There are certainly environmental factors, but mostly it's kind of in our genetic code. And so we'll see patients of all shapes and sizes and activity levels develop arthritis.
And does it get worse with age then?
It does. It is a degenerative process by definition, and so over time that condition will worsen. Something interesting about osteoarthritis is though that patients will go through periods of time where they have very mild symptoms followed by times of severe symptoms and then actually, a loss of symptoms again. So it can be a little confusing for patients, but over time if you chart it, they get worse as time goes on.
Okay, all right. Now, who is a candidate for this surgery?
So if we're talking about hip and knee replacements, kind of the imaging has to match the patient. And so I tell my patients all the time, we don't treat x-rays, we treat patients. And so they need to have end-stage arthritis on x-ray. They need to have tried non-operative management, whether it's through activity modification, formal physical therapy, anti-inflammatory medications, but given that a good effort, and then be medically appropriate to undergo hip and knee replacement. And again, those are conversations that you would have with your own surgeon.
And obviously, the pain level needs to be pretty high.
Absolutely, yeah, thank you. If a patient comes to me and has x-rays that show end-stage arthritis, that patient, if they're doing well and is functioning well, certainly does not warrant surgery, right? This is an elective procedure. This is not a clogged artery in your heart. This is not a tumor. This is a quality of life decision. Okay. And so pain needs to be part of it for sure. Right,
right. Now let's talk about the surgery itself. Are there new joint replacement technologies that we should be talking about?
There are. It seems like every day there's new technology. Yeah. I think at a place like the Cleveland Clinic, we need to be responsible about how we manage that technology and introduce that technology to our patients, and I think we do a good job of that. One currently is robotic surgery, and I'm sure a lot of people watching this have heard of that. We have robotic capabilities here. Okay. Like any new technology, we're trying to figure out exactly where it fits and for which patients. It certainly seems promising. It allows us to make very precise cuts. We know that it enables us to hit the target better, but sometimes we don't know exactly what the right target is, and that's where that divide can occur between, okay, we have this great technology, but does that correlate into better outcomes for the patient? Certainly early on we think it's going to, but like anything, time will tell, and we're responsibly adding that into our practices.
So is the robot itself kind of like helping or guiding the doctors for the incision? Because it's not actually doing the surgery, right?
One day probably will, which I'm a little nervous about. Yeah. So it does not help with the incision. So the incision and what we call the approach to the knee is the same. But what's interesting about the robot is that we're able to map the patient's anatomy preoperatively through advanced imaging like a CT scan. So it does require more imaging preoperatively. Okay. Then once in the operating room, we register the patient's anatomy, and we're able to basically virtually implant the joint replacement and to see what that's going to function like. And we can add stress to the knee and balance the knee virtually. Sure. And then once we decide on that plan, which is where the surgeon comes in and hopefully our expertise comes into play, the robot arm actually comes in with the saw. We're holding that saw, but it has what's called haptic technology, so it won't allow us to cut outside of the safe zone that we've created. So it helps us make the bony cuts. Okay. But none of the soft tissue work.
Okay. That sounds painful.
And the implants we put in are the same implants we would use if we did not use a robot.
Right, right. Okay, great. And so what does a total hip replacement look like, or knee replacement look like? What do we expect?
I have models.
Great. Yeah, let's do that.
So we were talking about knees, so let's start with knees. Hopefully this is on camera. So this is what a knee replacement looks like from the front. Okay, everybody doing well?
Yeah.
I think it's more important to look at it from the side, frankly. And I tell patients all the time, it should really be called a knee resurfacing. As you can see, we don't cut here, take the knee out and put a new knee in. We actually, at no more than about a centimeter anywhere, do we make a bony cut and then resurface the bones with metal on the end of the thigh bone, metal on the top of the shin bone, and then this piece of plastic snaps in between, and that becomes your new joint surface. So that's a total knee replacement.
So is that where the cartilage would usually be?
Typically be, yeah. What you see is silver and gray. That's where cartilage usually would be.
Oh, okay.
Okay.
Okay, great.
And then with a hip replacement, I don't have bony models to go with it. A little bit different is this is the femoral stem. It goes down inside the thigh bone. It's hollow, kind of like a PVC pipe.
Okay.
And then it has a ball that snaps onto the end of it.
Wow.
And then on the pelvis, there's a metal cup that goes into the pelvic bone. Again, with a surface that the bone can grow into it, a piece of plastic that snaps into that, which becomes your new joint lining, and then the new joint is a ball and socket.
Wow.
And that's how the patient has a nice pain-free joint afterwards.
That's awesome. Well, let's talk about recovery from this kind of surgery. Can I go home, or do I need to go to rehab after this?
Sure. The short answer is go home. You
go
can
home?
go home.
Okay.
So this has changed over time and changed dramatically. Let's see, I just said I started my training in 2004, so 14 years ago. I mean, over that relatively short period of time, we've seen a drastic change in how soon patients can go home and the fact that they are going home. So we developed care paths here, myself and several of my colleagues, to standardize the care, still with, specifics for each individual patient, but to try to standardize the things that we can standardize. And with that has come a significant reduction in length of stay, whereas it used to be 3.5 days. Some of our institutions, Lutheran Hospital being one of them, our length of stay is down to 1.2 days, so the vast majority of our patients are going home the next day. And then again, that discharge to home as opposed to a rehab facility is upwards of 80 to 90% of patients going home now, which is a big shift. It was a cultural shift for our patients, as well as everybody who's part of the healthcare team, but realizing that that's a very safe way to do it. Now, if patients need to go to rehab, whether they don't have any help at home or they are extremely deconditioned before surgery, we still set that up and it's still a viable option.
Good.
But certainly for the vast majority of patients, it's a one-night stay in the hospital. Some of them actually go home the same day, but that's a little bit different. But one-night stay in the hospital and then home. And
then crutches or no crutches?
So patients will need what we call a cyst device. Crutches can be a little cumbersome.
Yeah.
Most of our patients will use a walker.
Okay.
And that's usually a 3 to 4 week time frame. And then they transition to a cane.
Okay.
For another week or so. So you're looking anywhere from 3 to 6 weeks with some type of assist device and then nothing. Okay. And barring any certain special circumstances, most of our patients can put their full weight on it right after surgery.
Sure, sure. And I'm sure individually everybody's different, but what is the best recovery for a patient? What are they supposed to be doing? What do you expect them to be doing after a few months?
Sure. And so along those lines, again, to kind of go out further, it's, like I said, 4 to 6 weeks with an assist device. I tell patients, and what we see is about 3 months, you're 90% recovered. 3 months. The biggest thing they do from a recovery standpoint is really engage in the process. Okay, it's not a passive process. This is an active process. I tell patients, I work really hard for an hour to hour and a half. Their job's tougher, and they have to work really hard for 6 to 8 weeks. And in the end, we're both happy and get a really good outcome. Right. But the key is social support at home, if you can. Have people around. You're not going to be 100% dependent on them, but having someone around to help out is going to be important. But again, within 1 to 2 weeks, especially with hip replacements, I mean, patients are getting around very well. Now, there's some precautions we put on them early on. Okay. But I think most patients, again, especially with hip replacements, are kind of surprised at how quick that recovery goes.
And how fast is the pain supposed to go away?
It's variable. I wish everybody went away really quickly.
Yeah.
And I wish I could put my finger out. We do a lot of things now that we did not do in the past as far as helping with postoperative pain management, with local injections, different blocks that our anesthesia colleagues do, which has helped tremendously and helps reduce the amount of pain medications patients need.
Sure.
But there are still these kind of outliers where patients will have pain for a long period of time, but we manage them through that. By and large, The first 4 weeks or so
Okay.
can be pretty difficult, but it is really patient dependent.
Yeah,
So
yeah. I mean,
if we could figure out how to put our finger on that, it would be nice.
Yeah, my mother got a full knee replacement, I think a few months ago, maybe even last year by now, but she still has some pain going up and down the stairs whenever she bends the knee kind of like all the way back. And I never know, is this normal or should she go back?
So these are questions we get a lot, and I would tell you it's normal.
Okay, good.
I wish I could tell you that all of my patients have zero pain following knee replacement, but that's just not the case.
Sure.
And in fact, some studies will show us that 1 out of 20 patients not only have some pain after knee replacement, but actually are somewhat dissatisfied. Now, I think part of that is with the expectations that are set. So when we look at the knee, it's a very complex joint. So replacing a knee has a lot of variables at play, and so a lot of patients will have some residual pain after surgery. We looked at our own results, and fortunately we found that 98+% of patients here have a clinically significant reduction in pain, but that does not mean 0 out of 10 pain.
Right.
When you look at total hips, again, we'll have some patients with residual pain, but the vast majority of total hip replacement patients have little to no pain following that surgery.
Okay. Now, with limitations after surgery, can patients still kneel? Can they do sports for hip replacement? Can they still have sex? Are these limited?
Yes.
Yes. Okay.
In short is yes. So when we look at knee replacements, the limitations are really what the patient can tolerate for the most part. We get that asked a lot, can I kneel on it? The answer is yes. A lot of patients do not like the way that feels.
Right.
The old dogma was, oh my gosh, you can't kneel on these, they're going to explode. That's not the case. Most of us allow our patients to, but again, going back to the fact that a lot of patients don't necessarily like the way that feels.
Sure.
You know, it's kind of a corny analogy, but I use it a lot. If you take a car and you put new tires on the car and you drag race, you're going to have a lot of fun, but you're going to need new tires soon.
Sure.
Right? If you park it in your garage, you're never going to need new tires, but that's not really why you put new tires on it in the first place.
Right.
So that activity level, those restrictions, it's somewhere in the middle. The more you use it, the quicker it's going to wear out, but we do this to get patients back to active lifestyles. As an aside, I used to jokingly say, well, don't bungee jump or jump out of an airplane, thinking nobody's going to.
You never know.
I swear, I literally had a patient come back about 2 months ago. She had done both, and she had bilateral knees in, and everything went well. I don't recommend that.
Don't recommend that, no.
And then with hips, you can dislocate a hip, and so there are some precautions for the first 3 months or so that we put on patients as far as extremes of motion that the therapists go over with them. But again, after that, by and large, I tell my patients to do what they want, live their life. This is why we did it.
Okay, great. Now, looking at these models, a lot of metal pieces involved. Is security gonna stop me when I go through the system?
Potentially,
Do you have to let them know?
Yeah, they can set off metal detectors.
They can. Okay.
Pre 9/11, actually, we used to give out, and some folks still do, and some patients really request it, in which case I will.
Sure.
But we used to give out cards to patients saying that they have a total joint in, which helped expedite their movement through security. That does not help anymore. In fact, I was at the airport recently and saw this poor woman going through her bag trying to find her letter to say that she had a joint replacement, but it didn't. So it in fact caused increased time to get through security. But yes, you can set off metal detectors. There's unfortunately no way to circumvent that.
So just let them know.
Just let them know. And I mean, there are millions of people out there with joint replacements, so they're well aware of this.
Okay, good. I'm going to ask you one more question before we go to live.
Sure.
If we have 2 knees, if both knees are in pain or need replacement, do you recommend one at a time then, or how does that work?
So that's patient dependent. You know, a fair amount of data in the literature shows that there's increased complication risk with that.
Okay.
And it's more than double in a lot of studies. And so it needs to be the right patient. We actually developed criteria here to look at patients undergoing what we call simultaneous bilateral total knee replacements, and we actually just are in the midst of publishing that study. And the criteria that we set, it shows that if the patients are within those criteria, and they have to do with age, BMI, no active medical conditions, if they're diabetic, extremely well-controlled diabetes, those patients within that capsule do well. If you're outside of that, they have more complications.
I see.
So it's a long-winded answer to say if the patient fits the mold, they're extremely healthy, then they may be a candidate for both at the same time.
So it all depends.
But most patients, we recommend staging them.
Okay, great. All right, well, I'm going to go ahead and jump to some live questions that we're getting in. I have, first one here is Anne. Have there been any new treatments developed for, oh, that just went away. Let's see.
Anne left.
Sorry. Okay, Liz. Let's go to Liz. Hello, what can you suggest for my right shoulder? I have had 1 injection in it, but I have been told I have moderate to severe arthritis on both shoulders. Do I need more injections?
So similar to hips and knees, when you're looking at an end-stage arthritis of a shoulder, you know, at some point injections are going to fail to provide you the relief you're looking for.
Okay.
And if you've reached that point, Liz, I would recommend, seeing, preferably one of our surgeons here, but any shoulder specialist, to go through the same kind of conversation we're having here about hip and knees about the shoulder, because there are shoulder replacements that do very well. And again, if you've exhausted non-operative management for that, it's maybe time to see a surgeon.
Great. And then I have Steve. Do you believe that knee replacement should be done at earlier ages than previous beliefs? Mine was at 59, though my quality of life was horrible.
It's a great question, and it's a question I get a lot. And again, going back to this kind of old dogma that was passed down, was you have to wait as long as you can. And what's frustrating for me is I'll see these kind of arbitrary numbers set for patients where you have to wait till you're 50 or whatever that number is set.
Yeah.
I don't think that makes sense. I think we have to be careful about how aggressive we are at putting these into patients. But at the end of the day, again, if the x-rays match the symptoms, meaning they have end-stage arthritis, it greatly negatively impacts their activities of daily living, then I don't see any benefit in, if you're 42, somehow waiting till you're 52 to do it.
Okay.
The problem is you're probably going to need a second surgery down the road. And let's, for argument's sake, say that contemporary total knee replacements are going to last 20, hopefully 25 years. If we say the average life expectancy is 85, okay? So now you need to be 60 or older to where we say, okay, you're probably not going, there's still no guarantees, but probably not going to need a second replacement. And you're 45, why wait 15 years of misery, right, for this theoretical gain down the road? So I don't think there's a strict age. Again, we have to look at it responsibly and understand, we don't just put them in anybody. But if you have end-stage arthritis, you've tried everything and you're miserable, at least have the conversation about joint replacement.
Do most patients, or how many patients out of the ones that you do, actually come back for a second surgery?
So, well, given the fact that I've only practiced 7 years, so not many, hopefully, right?
Yeah, that's a good thing.
But what we see are our predecessors, our mentors, right? The folks who were doing surgery here 20 to 25 years ago, those are the patients that we're seeing.
Okay.
And with some of the developments, especially in the plastic that we use in the joint replacements, when we have to redo them, we're seeing less drastic of problems, more manageable, what we call revision surgery. Okay. And hopefully we'll continue to see that.
Good.
So when you need it redone, hopefully it's not a huge surgery.
Right. All right. Excellent. And then I have Judy. I had partial knee replacement on both knees, and I'm in serious pain. What can I do for this?
That's tough. There's many reasons why you could still be in pain. Sometimes the implant itself fails. So typically they're glued into place. It's called bone cement. If that bond isn't working, then it could be due to the implant itself. With a partial knee replacement, and I love partial knee replacements, I think it's great surgery in the right patient. The fact of the matter is your knee has 3 compartments. You've only replaced one of them. So underneath the kneecap or on the outside or inside part of the knee, depending on which partial you had done, can develop arthritis and be causing pain. So it would require, in-office evaluation, x-rays to try to determine what's the source of that pain.
Did you call that knee cement? Is that what it's called?
Bone cement.
Bone cement? What is that made out of? Just curious.
It's polymethyl methacrylate. It actually comes from the world of dentistry. Is where we borrowed that from.
Oh, very interesting. All right. And then I have Mary. Hi, so glad to see this feed. I had a total hip replacement 8 weeks ago. Been going better than expected, but my foot on my surgical side has been off and on, swollen since surgery. The doctor said it's normal. However, the past week or so, my foot has turned red, like a sunburn. Is this also normal?
That's another tough one. I mean, 8 weeks out, it can be. We certainly will see patients have swelling in the operative limb due to some of the things that we do during surgery. And so on and off swelling is not uncommon, but you also can develop things like gout, which will cause a red swollen foot and painful. Surgery puts you at risk for developing those types of things. We worry about blood clots. Typically, if it's a blood clot, it's not just the foot. We see more swelling, a more diffuse swelling pattern.
Sure.
Again, very hard to say exactly what's going on here. It may absolutely be normal. If there's any concern, that's certainly my belief is that's what our office is there for.
Yes,
and if I operate on a patient and they've called in and they're concerned, we get them in and we take a look and we see what we can see.
Excellent. Cindy, how long does a knee replacement last?
So we kind of touched on it. I wish I knew for sure. Again, going back to my whole car analogy, some of it depends on how much you use it. The other issue with orthopedics is that typically the contemporary replacements we're putting in have not been around for 15 to 20 years. They're based on their predecessors that we think we've made improvements to. So long-winded answer. I tell patients, and it's a big window, anywhere from 15 to 25 years. So I usually say average 20 is our hope.
Okay.
We'll see some fail early for reasons we're not clear.
Sure.
And then I'll see patients who had their knees replaced, 30 years ago, and they're still functioning
and they're
well.
still good.
So it's hard to know
Amazing.
for sure.
Great. And then I have Cindy again. How do you know the right age to do a knee replacement? And we just talked about
it's not. I wouldn't put an age on it. I have patients who are actually 50 who aren't healthy enough to undergo joint replacement, because patients also worry about getting too old, and I have 85-year-old patients who are in tip-top health and absolutely good candidates. So it depends on the whole picture.
Okay.
There's no absolute number you can put on that.
And your quality of life, right?
Correct.
Yeah. Melanie, I think it's better to stay in the hospital for 2 to 3 nights given the medication they're taking. I think the stay has shortened due to insurance and the quick recovery of the surgery. So I guess that's kind of more of a comment.
We get that a lot, and I understand that sentiment, and it's hard to, I guess, first and foremost, I would tell you that certainly my goal as a surgeon, and I would like to think that the goal of the Cleveland Clinic as an institution is we put it as one of our main things as patients first.
Yes.
And some decisions I think can look that way, but we've looked at our own data, and other places have looked at their data and shown that the shorter length of stay and the higher rate of discharge to home absolutely has improved outcomes. Mm-hmm. That's not to say there are patients that get readmitted for one reason or another, and we're working very hard to reduce that even further. But we certainly saw no uptick in readmissions as we shrunk our length of stay. In fact, a decrease. And there are some patients who medically, for whatever reason, or depending on what happened in surgery or what's transpired over the 10 hours after surgery, do stay 2 or 3 nights. It's not, we don't put every patient, discharge them post-op day 1, the day after surgery, regardless.
Right.
And so I hear that sentiment. We try to assess each patient and do what's right for them for sure.
And just like you mentioned, if there's nobody home or if they need more care, they can go to a rehab
center.
Correct.
Correct.
And then Paul, do cortisone shots accelerate the degeneration of joints?
That's a good question. You can see in patients who have had multiple steroid injections deposits in and throughout their joint. So I think for me, when I use that as a treatment option and for how long I'm going to do that, kind of depends on what we're using it for. Mm-hmm. So if a patient has moderate to severe arthritis, I mean, not to sound crass, but the horse is kind of out of the barn, so to speak. So even if it's causing some degradation of the joint, but in the meantime providing them significant relief to avoid surgery for whatever reason, maybe they can't fit it in their schedule, don't want to do it, I think that's fine. If we're using it for something more upstream, so they have knee pain, x-rays look really good, I will give patients a corticosteroid injection, but to your point, I will not, repetitively inject that knee.
Okay, so it's like a one-time kind of injection?
Again, depending on what we're treating. Depending on what we're treating. Well, we have some patients who we use, we can't do them any closer together than every 3 months. Okay. We'll have some patients who every 3 months come in, maybe they're not medically appropriate for surgery. They get 10 to 12 weeks of relief from their steroid injection, and we inject that joint.
I see.
I think that's okay too.
Yeah. All right. Great.
Again, patient dependent.
Sure. And then Carol, what are the odds of good results from bilateral knee surgery?
Very good. Again, if you look at quality of life improvement from surgery, number 1 is open heart surgery. You save a patient's life. Number 2 is cataract surgery. Yeah. Number 3 is total hip, and behind it is total knee. So it is great surgery, including bilateral knee surgery. Sure. Again, I like to think that the criteria that we've set in place here help pad those results, if you will, knowing which group of patients are going to do well from bilateral knee surgery. And so the results are very good. Great. Very, very good.
Excellent. And then Jan says, my daughter has rheumatoid arthritis. She has gone in for multiple torn, is it labrum?
Okay.
Her funeral head is a bright red from inflammation. She's asked for a hip replacement, but her doctor says it won't help her. If they remove the inflamed, am I saying this, femoral head?
Femoral head, yep.
Femoral head. Would that not stop the pain?
In that setting, so rheumatoid arthritis and other inflammatory arthritis, arthritides are different than osteoarthritis.
Okay.
That being said, if you have end-stage rheumatoid arthritis with loss of cartilage, again, the mechanism by which you lose cartilage is different.
Yes.
Typically you are looking at joint replacement.
Okay.
There are other biologic medications that affect your immune system that a rheumatologist would manage, not an orthopedic surgeon, that will have a lot of patients on. That have some risk but have done wonderful things for that patient population in general as far as saving their joints and allow them to maintain their activity levels. Again, I hate to say it's a case-by-case basis. It would depend on what the x-rays look like. If those x-rays show end-stage arthritis of that joint, I don't think going in and resecting that synovium is going to be of benefit.
Okay, great. And then Mark wants to know, is it possible to avoid a hip or knee replacement? What are other treatment options?
The best way to avoid is just to be able to tolerate, again, because it's a quality of life decision. If you can tolerate the symptoms you're having, barring a couple of exceptions, there's no really harm in waiting and holding off and not doing surgery. As far as upstream, it's weight management, it is low impact exercising, it's good nutrition, all those types of things that are frankly good for every condition that we suffer from. Right. There are other non-operative modalities. We talked about steroid injections. Again, doing nothing to change the trajectory of the disease, really. It's just trying to decrease the symptoms that the patient suffers from. There are things like stem cells. There are people working very hard here to look at those. There are some clinically available. Insurance does not cover that. It is out-of-pocket expense. I think there's very little risk, but there certainly is not science to date to show any improvement. I can pretty much with no uncertainty say that it's not going to grow cartilage back on the knee, but it may provide symptomatic relief. So that's an option. Other things, PRP, platelet-rich plasma, again, to try to improve the symptoms. We have not figured out how to stop the process or reverse the process for that matter.
Right, very good point. Amy, what do I need to do to prepare for surgery?
Any medical comorbidities get absolutely optimized. There are risk factors that we cannot change, and there are modifiable risk factors. So any modifiable risk factor, whether it's heart disease, weight, diabetes, smoking, all those types of things that can be modified, modify them to put yourself in the best position to not have any complications following surgery. Stay as active as you can. Sometimes that becomes difficult with a painful joint, which is why you're having the surgery. And then again, try to recruit social support for when the time of surgery comes, that you're ready. It's probably going to be 8 weeks or so off of work if you're employed, just to kind of keep that in mind as far as
8 weeks off?
I tell folks 8 weeks. I've had patients go back after 4. I've had patients need 12 weeks. We did a study here at the Cleveland Clinic. He's a hand surgeon now. He's one of our ex-residents. Actually looked at it, and it wasn't what job patients had. It was actually what resources they had when they weren't working. So self-employed patients got back to work really quick, whether they owned their own construction company or they were accountants. When they weren't working, they weren't being paid, which makes sense. So again, the patient has a lot to do with when they get back to work, but I think a reasonable estimate is 8 weeks.
Okay, great. Marilyn, I just had a knee replacement last July. What kind of bend should I have? It's about 105 now. Should I have more? Can do everything but kneel. Thank you.
I would tell you that if you've had it a year ago, that a 105 is going to be what you're going to have. Okay. What we know is that typical American life, 105 degrees of flexion is plenty to typically do most of the activities that we enjoy doing. What it should do or shouldn't do, I don't know. The big thing that predicts how much it moves after surgery is how much it moves before. And so some patients will have bad arthritis and they'll have full range of motion of their knee. Those patients typically get a lot of range of motion following surgery. But before surgery, if you had very limited range of motion, there's a good chance that impacted the fact that you have 105 degrees of motion.
Right.
The implants themselves can tolerate and see up to 140. Those are outliers, though. The vast majority of patients do not get that much flexion, nor need it.
Okay, good to know. Dan, what are the best exercises to perform after surgery?
Again, I would say low impact exercises. Early on, especially with knee replacements, you're going to look at quad strengthening, so your thigh muscles.
Okay.
When we do something as small as a knee scope, that muscle can shut down. So this is a much bigger surgery than that. And so it can take patients a long time to get their quadricep muscle built back up. So focusing in on those exercises post-operatively are important. Not to mention that pre-operatively, arthritis starts to shut those muscles down too.
Right.
But short of that, I recommend cycling, swimming, which can be somewhat cumbersome, but it's great exercise. It's low impact. Walking. Patients will ask if they can run. Again, going back to that car analogy. You can, but I would love to see you do ellipticals or, like I said, cycling or something like that.
How about water aerobics? I think
great.
like underwater
Absolutely.
is
perfect.
Great. Okay, got it. Anne, have there been any new treatments developed for chronic bursitis?
Chronic bursitis is tough, and we'll see that in patients who do or do not have arthritis. A lot of patients get sent to me to have their hip replaced, and they have what's called trochanteric bursitis, which is lateral-based hip pain. Okay. You can see that after surgery as well. The short answer is no, unfortunately. That's one of those conditions that seems to be recurrent. Again, the treatment really hinges on physical therapy, stretching, ice, non-operative modalities. There are certain times where we'll take the bursa out. I've not seen good results with that. Not, you know, if you've had that done, I'm not saying it's terrible. I think unfortunately it's often a recurring kind of chronic issue. Try to do low impact exercising. Over the counter medications is needed.
Okay,
we can do some injections at times.
And then back to Liz. I read about a knee replacement surgery that does not cut tendons or ligaments. Is that common now?
So I think this gets to the responsibility of us as orthopedic surgeons, just being careful about how we word things. There are certain techniques that we've learned to make the surgery less invasive. Minimally invasive surgery was all the craze, and I think a lot of good things came out of it. We have better instruments. We just have a better know-how of how to do the surgery with less damage to the tissues.
Okay.
I think it's semantics, whether you're saying, if you can feel comfortable saying I don't cut across tendons, you cut alongside tendons. The fact of the matter is we have not discovered a magical way to put this implant in through a hole that's this big, right? So we still have to get into the knee joint.
Yeah.
And there are certainly ways to do it where we damage muscles and tendons and ligaments less than others, and I think most contemporary surgeons today respect that and understand that and do that.
Sure, great. Lucille, how long does a knee replacement last? I had mine done about 20, 25 years ago, and now it clicks now and then.
So that's a great example, right? It's 20 to 25 years, and if all you're having is a little bit of clicking, that's great. It seems like it's doing well. All total knee replacements, whether the patient notices it or not, will click because they're metal and plastic, and so they'll come together and then go apart and then come together, and that makes a click. The reason, Lucille, you may be noticing it more now than you were before is what wears out is that plastic, and so that plastic fills a space. And as that plastic wears out, that space gets looser, and patients will report more clicking, the sense of instability, maybe not trusting the knee. Certainly 20 to 25 years out, I don't know when the last time you had an x-ray is, I would recommend getting in to see somebody. It's not, I don't want you to think it's an emergent thing, but I would in the near future have an x-ray just to see what the status of your knee replacement is for sure.
Okay, great. Jason, are you familiar with is it Arthrosis conversion to total knees? If so, what are the results? And what is that?
I think I know what that is.
Okay.
So Arthrosurface is a way to treat, so arthritis, what we're talking about here today, is kind of a diffuse loss of cartilage throughout the knee, either one side or all three parts of the knee. Arthrosurface is designed to treat patients who have a focal lesion of cartilage, typically from like a trauma. Okay. So just as we talked earlier about a partial knee replacement where the rest of the knee can wear out, with an arthrosurface you have even more of your knee that can wear out. And at times that arthrosurface needs to be taken out and converted to a total knee. I don't know of any study looking exactly at that. If you look at the results of a primary total knee, meaning first time around, and then you look at the results of what's called a revision total knee, going back into a total knee and having to redo it, a primary total knee results are much better. Something like taking an arthrosurface to a total knee are going to be closer to that primary total knee result than to a revision. It's a pretty easy surgery. There's little difference in whether we're just doing it the first time around, but I can't give you the exact results.
Sure.
But they're good.
Okay, good. Robert, what hip replacements options are there?
That's like kind of saying what car could you buy. I mean, there are multiple makes and models, but they all function pretty much the same way. I think hip resurfacing is kind of a divide. We have one of the most prolific hip resurfacing surgeons here at the Cleveland Clinic, his name's Peter Brooks. And there's a select patient population that's appropriate for.
Okay.
In general, these aren't exact, but in general, 55-year-old men and younger. It's only for men. But short of that, the hip replacement options, there's different bearing surfaces. Most of us in this day and age use a ceramic ball on a plastic liner. I'm sure you've seen metal on metal hips and all the problems that have come forth with that. So again, the options are subtle. It's like deciding between a Ford or a Chevy, sort of. So lots of options, very similar in the way they function.
You said it's only for men. Are the hip replacement pieces, are they all separate, kind of female-male, or?
So hip replacement, that's hip resurfacing, just to say, just for male. I want to be careful what I'm saying, which is different than a total hip replacement. They're not different, but we have a multitude of sizes. So I call it off-the-shelf customization. It's not, they're on the shelf, but we have 1 through 22 as far as sizes are concerned, and so we can fit any patient's anatomy.
Okay.
And so obviously, typically for women, we're using smaller sizes in general, but we have sizes to fit any individual.
Linda, what about scar tissue on a knee replacement? Does it have an impact?
It does. Some patients, for one reason or another, like some patients will keloid, which you'll see kind of big scars on their skin. Sometimes we'll see that type of process occur within the knee joint itself. We call that arthrofibrosis. You know, there's some ways to manage that. Sometimes it's a very difficult problem to manage. Right. Typically what stems from that then is a knee that's stiffer than you would like, so decreased motion. And again, there are patients who develop scar tissue rapidly and aggressively and some that don't. I don't think we necessarily have a good handle as to why some do and some don't.
Okay. And then Wanda wants to know if there are any concerns with type 1 diabetes having hip replacements.
Absolutely. So unfortunately, diabetics are at increased risk for complications, specifically infection. Infection is kind of this terrible thing, unfortunately, that can come from joint replacement. Now, fortunately, it's very rare. It's somewhere around 1% chance. Yeah. Diabetes puts you at increased risk for that. Being an insulin-dependent diabetic certainly does. We look at hemoglobin A1C, which is a decent test to look at the overall management of blood sugars on a daily basis over an extended period of time. Okay. There's no hard number. You know, we like it certainly to be 7 or better. The closer to 6, the better. You know, again, if it's kind of a complete picture. If a patient is a type 1 diabetic, their A1C is 7.2, but they don't smoke, they're not overweight, then I think it's okay. But if you have those other risk factors, then you really, like I said before, those modifiable risk factors, you really try to have to manage those as best you can before surgery.
Sure, because they apply everywhere.
Correct.
Right?
So the key is tight glucose control.
Okay, great. And then Pam, how does or how bad does your knee have to be in before you can consider a replacement? Mine is bone to bone.
So if your x-rays show bone-on-bone arthritis and you can go jog 5 miles, don't get your knee replaced. If your x-rays show bone-on-bone arthritis and you second guess whether you're going to go out to dinner with your significant other or your children or your friends, then that's time to start contemplating knee replacement. Right. You know, I'll have patients who come in and say, oh, my knee's killing me. I play 18 holes of golf and by the end I need to take an ibuprofen. I said, well, I don't think that's reason to have your knee replaced. I feel for you, but I take them too. And then other patients who their family's like, they stop getting off the couch, they won't do anything, and that patient need to kind of help feel better and more comfortable about the results of joint replacement. So again, going back to your question, those x-ray findings have to match what impact it's having on your daily life.
Sure, and your symptoms. Great. I'll have 2 more questions for you before I let you go.
Okay.
Brenda, what would swelling and pain behind the knee indicate?
A lot of times that's what we call a Baker cyst or a popliteal cyst. That popliteal fossa is the posterior part of the knee. That's typically from inflammation within the knee, and then there's kind of an anatomic variant that allows that tissue to get out into the back of the knee. Sometimes we'll see that rupture, and patients will all of a sudden have calf swelling. But again, it's typically the issue is within the knee. A lot of times, again, treatment is to try to treat the underlying condition. If it's arthritis, low impact exercising, maybe an injection. On occasion, we will actually go after the cyst. I have some colleagues, I don't do it myself, but under ultrasound, we'll aspirate that cyst or suck the fluid out of it and maybe inject something. In the back of the knee, that's where your blood vessels and your nerves are, and so you have to be a little bit careful. Wow. But again, it's more of a symptom of what the underlying issue is.
Right. All right, and then I have last question from Gracie. Is it true that you can only have 2 replacements in your lifetime, and if so, why?
It's not true, but it is one of the reasons you can run out of real estate, so to speak. So it's one of the reasons that you don't want to embark down that road and start down that road until your symptoms warrant it. Right. We have patients, unfortunately, who have undergone multiple surgeries for one reason or another. You start to run out of bone. Each time we go in and have to redo it, we run out of bone. In this day and age, we have quite a few tools in our belt to replace bone. What also becomes a problem is the soft tissue surrounding that implant. So there is a limitation. It's certainly not 2.
Okay.
And it's different for everybody, once again.
All right, great. Well, that's all the time that we have for today. But before I let you go, anything you want to tell our audience that maybe we haven't touched on?
I know.
We kind of talked about a lot.
I think so, yeah. I've enjoyed my time. I think you guys have had great questions. I appreciate it.
Great. Thank you. Thank you so much. And then for more information on knee or hip replacement, go to ccf.org/treatment guides for a full selection of health guides. And then look for knee pain, hip pain, or joint replacement guides. And for more health news information, you can make sure you're following us on Facebook, Twitter, Instagram, and Snapchat at Cleveland Clinic, one word. Thank you so much. We'll see you next time.